Thank you. I can see Professor Dunning. It's a really privilege for me to introduce Professor Dunning, who is a member of the Order of Australia and a distinguished life fellow of the Australian College of Nursing. He is a credential literate, diabetic educator, and life member of the Australian Diabetes Educators Association. She is a former vice president of the International Diabetes Federation. At the moment, she is the chair of nursing in Balwan and Daikin University Partnership and midwifery. Her research focus is on elderly people with diabetes and palliative and end-of-life diabetes care. She has published widely many books, many original articles, and she has contributed to many diabetes care guidelines. It's a proud privilege for me to invite her to make her presentation. Professor Dunning, please.
Thank you very much. Could I please ask that you share my slides for me so that I don't have the hassle that we had last time, if that's okay, please? What I'd like to do in the short time is describe the how to teach rather than the what to teach, because what to teach depends very much on the person that's sitting in front of us or the people that are sitting in front of us, regardless of whether they're people with diabetes, which is primarily the work, or whether it's other clinicians, which is a lot of my work as well, and discuss some of the essential communication skills that we need to effectively teach and some teaching tips. You will note that I am repetitious and summarise as we go along. Next slide. Don't know why I can't control them. Yeah. So some of the key messages is that education is about a great deal more than words. Words are part of it, but it's an art and it's underpinned by science, and there's a great deal of science around the effects of education on HbA1c and various other metabolic parameters, provided the messages are tailored and they fit with what the person needs at that point in time, and that there is repetition. And I'd like to point out that if the teaching is not working, in other words, the person isn't making the changes that we so desperately want them to make, that's a sign that we as the teacher needs to change, not keep trying to change. If we're trying to change someone and they're not changing, we need to change what we're doing and trying something different. Next slide. So it's important to this is from palliative care, it's not really from diabetes education, but it's equally important. People will not remember what you did, they will not remember what you said, but they will remember how you made them feel. So we want to make them feel respected, that we understand and that we're there to help them. Next slide. And that there are various definitions of diabetes education, and I've chosen this one. The reason I've chosen this one is it talks about an ongoing process that facilitates people to acquire knowledge and skills and the ability necessary to undertake diabetes self-care, so that we don't have those awful complications, and including mental health issues, and that their life experiences are guided by evidence-based standards. This is part of what education is. Next slide. Sorry, it's clunky. This is a very complicated slide. This is a perfect example of how not to teach. There's too much on this slide. You can't read it all, but it's talking about to developing an individual care plan that conforms with guidelines and standards, that involves a team, that encompasses comprehensive reassessment, as we heard from the previous speaker, that there are regular medicine reviews as part of that, and that we use quality use of medicine. In older people that I'm often dealing with, that's de-prescribing and stopping polypharmacy as much as possible where it's safe, and facilitating independence as much as possible. We don't want them to depend on us. We want to have a partnership with them. Next slide. And importantly, there is communication and documentation so that the next person that sees that person with diabetes knows exactly what's going on in their education or their management. So it's essential that we reflect on who we are as teachers and clinicians, and our attitudes towards people with diabetes and their families, and the teaching style that we adopt. And it's very, to me, I love stories, and a great deal of healthcare is about stories. We take a medical history, we ask people what their needs are. So language is really, really very powerful, and stories very powerful, and we need to use that language very wisely. And there's an old saying in my culture that says, the least said, the soonest mended. So you don't go all out to tell them everything you want them to know in one lesson, that you pace it out, go at their pace, and watch out that we're not using inappropriate language like diabetic and control and various other words that we know from research that has negative impact on the way people see themselves as people with diabetes. Next slide. We need a plan, like we need a care plan, we need an education plan. And if we don't have some kind of a plan, we could end up very well being somewhere else. And the people that know me very well know that I get lost, very easily get lost. I have no sense of direction, so I need a plan. But a great deal of education is actually opportunistic. It happens at the teachable moment. It doesn't necessarily happen because you want it to happen. The person comes with a question. For example, I had a lady drop into my office before we went into lockdown, and she'd run out of her insulin, and her dog had diabetes, and she'd run out of her dog's insulin because what her practice was is that she used all her insulin, then she used the dog's insulin, then she went and got some more insulin. So that was a one-off encounter, and when I spoke to my vet about it, he said, well, I know this person very well. She does that all the time. She's very non-compliant. So what was an opportunistic teaching moment there? I'm still trying to work it out. Next slide. So in other words, that I've just told you a story. Facts tell, but stories actually sell. And we know that there are facts in the newspaper, but what sells a newspaper is not necessarily the facts, it's the stories that go in them. What sells great fiction is a story. What sells an education program is a story that's attached to some kind of facts. So learning how to be able to tell those facts in a story that sells is a really great art. Next slide. It's the afternoon here. One of the greatest skills we can have as health professionals is actually being quiet and listening. And one of the sad things that often happens is this Charlie Brown is a well-known comic character, and he failed story listening at school. And sadly, we often fail story listening too as health professionals or as clinicians. Next slide. Another complex slide. And the effective education is a respectful art and science, which I've said. It's part of an integrated process. It can be formal or opportunistic. Listening is essential. Listening is actually central. And if you're a really good storyteller, the person will listen, and forming a relationship with that person is really important. And probably the most key point on this slide is the learner controls what they learn. You might have control of what you tell them, but you don't have control of what they learn, what they take away from that message. Also, another key point is that family carers often play a very vital role in education. Sometimes the person with diabetes is just overwhelmed by everything, that the family carer will hear it, but they might not hear the same thing as the person with diabetes. And so we need to be checking for understanding as well as we go along. Next slide. And we know that I'm talking, there's two people in the conversation here because it makes it more challenging if there's more than two. But the box in the middle, the beliefs, the attitudes, the values, etc., these belong to the communicator or the teacher. They also belong to the learner. And they may not all be exactly the same. They may not all be operating on that same day, but they're going to affect what the communicator says and what the receiver hears. So we need to be mindful when we go into a teaching session, how we're feeling on the day, what the environment is like, how the person with diabetes is. If it's in a ward situation, it's not a great teaching environment. And what we mean may not be what the receiver actually hears. Next slide. Sorry, was that a question or? This is an important point. It's a card, but it's making a very important point here. There are two people that went into a consultation with a doctor. We don't know which of these two ladies is the person with diabetes. What we do know from what's on that card, the doctor told me to stay young and exercise and eat the right foods. And the other lady says, I thought he said to buy nice shoes and accessorise. So two different messages. What we don't know here is what the doctor actually did say. So we don't know. There are three people in that conversation and they all heard something different and they all took something different away from it. If the lady in yellow is the one with diabetes, she's going to go out and buy shoes and accessorise. Not worry too much about the other diet because we haven't told the story in the right way. Next slide. So another story says that people speak two languages and only one is verbal. What this means is that a great deal of a communication is non-verbal. It's what we can hear, what we see, what we smell, what the noise is like. It's what body cues. Is our language, body language, consistent with the words that we're speaking? Very important that most of a communication session is non-verbal. 60% or more is non-verbal. So we need to be mindful that we're giving consistent verbally and visually consistent languages. Next slide. And we need to be mindful of literacy, health literacy and various other social literacy and various other forms of literacy. But it's very complex. We know that, yes, they're in Australia, we talk about they're in socioeconomic status such and such, which means they're probably not gone to school at all or maybe only have basic school. But it's a whole lot more than that. People may not have a lot of education, but they can be very savvy. And literacy means that it's the way they obtain information, the way they process that information, if it's in a format that they can understand, that they understand the language system, that, you know, the grammar, the spelling, the way that we actually present the language, which way we're writing it. We're very multicultural in Australia, so we can't just use English language. We have a whole lot of different languages, information in different languages, and then they have to interpret that for themselves and add it to their memory bank. and be able to then retrieve that information at a time when they need to use it. So we know that health literacy is a strong predictor of health outcomes, service utilisation and healthcare costs. Next slide. And not only is it written language, but it's also the electronic messaging and other forms of communication skills, but it's the design and the readability. We've got 50,000 pictures on a page. Have we got too much type, as I have on a lot of my slides deliberately? What about the text colour and the contrast with the background colour? Is there white spacing around it so there's somewhere for people's eyes to rest as they move through a screen? Do we paraphrase every now and again? Is it easy to use? Is it intuitive? That we need to be thinking about these things, not just what the message is, it's how we present it. Next slide. We know from research that clinicians use 3 voices: the doctor or the nurse voice when we're seeking information, when we're asking them for a medical history or an education history, we use one kind of voice. If we're giving information, we tend to put on our teacher voice and we use a different sort of voice. But if we're encouraging people, if we're trying to counsel people, we use the fellow human voice. And that's the voice that people are most likely to respond to. And that's the voice we should be using in all of those guises when we're seeking information, when we're giving information, and when we're being nice to the person. Then we need to use that empathy, show empathy, show them, treat them with dignity and respect. Next slide. You recognise this man from your continent, and going back to listening, it's impossible to listen without silence. For example, if we're talking, we're not listening. So we need to be listening quietly. Next slide. From my own country, our Aboriginal Torres Strait Islander people have a word for this on the next slide. It's called didiri, which is a very rhythmic sound, and it's about being connected to the still, quiet place within. So you're listening from a place of being centred, a place of being respectful, and a place of stillness. And this is the rainbow serpent, which is a very important part of our culture. Next slide. It's also the same concept from the Asian, Chinese cultures. And that's, again, whole person listening from the eyes, the ears, their undivided attention, and listening from the heart. So you can see it's not just something I've made up, that listening is really, really important. And being a dog lover, I have a little book on my bookshelf called Listen Like a Dog. Listening like a dog means your whole body attention, which is what these slides are saying. Next slide. But what we find out, and very sadly from 2018, so relatively recent research, is that clinicians ask a question, and within 11 seconds of asking that question, they actually interrupt the person. The person hasn't even had time to think through what the question actually means, let alone answer it. Whereas if we don't interrupt them, they will tell us within 6 seconds what they want, what they need, what they're there for. And sadly, that the person's agenda, what they're needing, is not addressed over 80% of the time. So you can see that disparity between 11 seconds and 6 seconds, that if you actually be quiet and listen, it's actually saving time, not wasting time, as my colleagues often say to me. Next slide. So the teaching environment is an important one, and we don't always have the luxury to sit down and have a really nice environment with a cup of tea. But we must do our best to make it as caring and nurturing and as respectful as we possibly can, where the person feels safe to disclose information. And sometimes what they're disclosing and what we're finding it difficult to, in my research, giving bad news is that it's about talking about cancer and end of life and those kind of things. It's really quite difficult for a lot of clinicians. It causes a lot of moral distress. So we have to make them feel safe where they can raise these issues and feel safe to do so. And that is not necessarily a place, but a feeling that they get if we're deeply listening. And we make sure that they've got their glasses and their hearing aids and any other aid that they might need if that's called for. Next slide. And obviously the physical location, minimising distractions and those kinds of things, not making it too long, and just being mindful of these kinds of impacts on the amount of information people can actually assume. Next slide. People come with all of these explanatory models that we've talked about these earlier. So this is a recap slide. But going down to the second last point is that the relationship is a current relationship, but what about past relationships that we might have had with that person, that they can impact on the kind of conversation that we might have with them. Because it's diabetes, we're likely to see the person over and over again, so we can build up that story over time, whereas in some other professional practices, we don't have that same luxury. Next slide. So there are many ways to teach. We need to reflect on what is our teaching style, and do we have a teaching style? Why do we teach that way? Is it because we're familiar with it? It's the way we were taught in medical school or diabetes educator school. But if that's the case, will it actually suit the individual that's coming in through the door to see us in a minute? And how will we engage other people in that conversation? Like interpreters, we work through a lot of interpreters in many of our hospitals in Melbourne because of the multicultural. What about family members that are often interpreting for their family? And that's not necessarily a good thing, because they may say things that, and they may disclose things that the person doesn't want disclosed. So being mindful of privacy and confidentiality as well. Next slide. And don't forget role modelling. Role modelling is a very, very powerful learning. We may not set out to be a role model, but we may, like these two gentlemen didn't set out to be that role model, but you can see the powerful effect that they've had. They're all doing the same thing. That little boy is going to grow up and probably role model that for his sons and daughters. But what is not necessarily appropriate role modelling, for example, a smoking health professional or the people who are out there eating inappropriate food, not exercising, these role models are not the kind of role model that we want to be giving if we're saying one thing and we're doing another. Next slide. This is a slide from a movie called The Dead Poets Society, one of the greatest teachers ever portrayed. There are many, many great teachers portrayed in movies, Goodbye Mr. Chips being one of them, a sonata for Mr. Williams, And here, this is the Dead Poets Society. This teacher actually engaged with this is a school, it's not diabetes education, but there's much we can learn in the way he engaged with all the students in the class, where he had them debating, where he got them actively learning, really actively learning, and not just sitting there lecturing at them like I'm doing with you today. Next. And he formed those respectful relationships in order to make that happen. There's a lot of respect in his teaching. Next slide. And what I think is, this is my favourite explanation, I guess, for teaching, is it's making connections by solving jigsaw puzzles. The person in front of me is a complex human being. The picture on the outside shows me something about it, but not what the finished picture. Can't see inside of them. I don't know what they're thinking. I don't know what they're feeling unless I ask them, and they share that with me. So in itself, each piece is very abstract. It doesn't make much sense if we just look at a piece of a puzzle. But if we put it and fit them all together, then we can see what that picture is all about. And that might be through trial and error and might build up over time. But this is the way that a lot of diabetes education actually does happen, is that we build it up over time rather than in sitting in one go and building that jigsaw puzzle. Next slide. And here is, again, the individual controls what they learn, and we've all had people sitting there and say, teach me, I dare you. I don't really want to know what you're trying to show me. I'm going to learn what I learn, or I'm not going to learn anything. And you might not get there for the first time or the second time or the third time. But if you're persistent, you're respectful, generally there'll come a point in time when they are ready to learn. The challenge is picking it and listening when they are. Next slide. Giving information is a challenging thing. I spent time trying to think what would I put into these slides, and so some of the key points here are recognising that children and adults learn differently. Children are still learning how to learn. Adults have learned how to learn, but they may not learn the same way as they did learn in school. Concentrate on the main message and use a stepwise approach. Don't try and give it all at once, but you have fun. Use role plays, use stories, use cartoons, have discussions, use conversation maps if you've got those, draw pictures for them. Next slide. Engage, try many things that will engage them. So they're likely to learn if they understand what you expect them to do, what you want from them, and that you understand what they want from you. And you go from what they already know. You don't just launch out to something that's totally unknown. You go from simple things to more complex things that they're building on, and that you support things with facts. Some people want to know the facts, some people don't want to know the facts. And you teach, importantly, at a teachable moment. And that may not be the most convenient for you, but it might be the most convenient for them. And that you are realistic, your expectations are realistic. Next slide. Nearly there. And so realistic expectations is really, really important. I simply can't run fast enough to get cardiovascular benefits. And if we look at the person who's giving the advice about running fast enough to get cardiovascular benefits, could probably do with a bit of fast running themselves. So being a role model, again, here's a role model, but also being realistic about what we're expecting of people being able to do. And don't forget that with the hare and the tortoise, it's actually the slow old tortoise that got there first in the end. Next slide. And just to finish with a couple of my mantras. This sits behind my computer when I'm at work and not learning from home. I never teach my students. I only attempt to provide the conditions in which they can learn. And if I can achieve this, and I'm not saying I do all the time or even half the time, but this is a key point, is that provide the conditions in which they can learn is really, really important. And I'm sure you all know Albert Einstein, who was much more than just the person that... The other important, this is a nursing theorist from some time ago now, but the spaces where the patient and the nurse meet, or the doctor meet, becomes the arena where practice develops. Praxis is broader than the science guiding it. So what this is saying is you have to have the art as well as the science in order for praxis to occur, reflecting in and on the practice. Next slide. And last, I think, the summary slide is the teacher, if he is indeed wise, does not bid you enter his house of wisdom. What's in my mind is really immaterial, but I need to lead the learner to the threshold of their mind. And why I've put this dog picture here is because it's very forward-looking. They're disparate personalities, mice and cats and dogs. They're doing impossible things by riding a bike, but they're all going in the same direction. They're all respectfully honouring each other. And that is my talk. And thank you very much for listening. And I'm sorry that I was able to share my screen and it worked yesterday. So thank you for being forbearing and for sharing my slides. Whoever did that, I appreciate it.